In this video, I will discuss on acute otitis media. Acute otitis media is a common problem in early childhood. Most children have at least one episode by the age of 3 years. Peak age of incidence is 6 to 18 months. Most children and young people get better within 3 days without antibiotics. The most common bacterial pathogens are Streptococcus pneumoniae, non-typable Haemophilus influenzae, Moraxella catarrhalis. The respiratory viruses such as respiratory syncytial virus and influenza virus are associated with pathogenic bacteria in about 15 to 20% of the cases. The clinical manifestations of acute otitis media. There can be local and systemic symptoms. The local symptoms: earache, otorrhea. In small children, tugging or rubbing of the ear indicates an earache. There can be systemic symptoms such as fever, symptoms of upper respiratory tract infection, irritability, restless sleep, anorexia, vomiting, diarrhea, and also lethargy. If you suspect acute otitis media, examination of the ear with an otoscope is mandatory. To visualize the tympanic membrane in young children, the pinna is pulled in horizontal and backward direction, and in older children, pinna pulled upward and backward towards the occiput. Now let's see the otoscope evidences of acute otitis media. The abnormal tympanic membrane. Redness due to the dilated vessels. Opaque drum. Normally, the drum is shiny. Bulging of the tympanic membrane. Impaired drum mobility. Acute purulent otorrhea. These are some of the otoscopic appearance of tympanic membranes. It shows the normal, mild bulging, moderate bulging, and severe bulging of the tympanic membrane. The pink tympanic membrane often seen with fever or upper respiratory tract infection. Air fluid level behind the tympanic membrane with otoscopic evidence of middle ear inflammation. Distinct erythema of the tympanic membrane. The diagnosis of acute otitis media should be made in children who present with moderate to severe bulging of the tympanic membrane or new onset of otorrhea not due to acute otitis externa or mild bulging of tympanic membrane and recent onset of, that is less than 48 hours, of ear pain or intense erythema of the tympanic membrane. The complications of acute otitis media. There can be intracranial and extracranial complications. The intracranial complications are facial nerve palsy, acute mastoiditis, inner ear labyrinthitis. The extracranial complications can be meningitis, extradural or subdural abscesses, sigmoid sinus thrombosis. The management of acute otitis media. The pain can be managed with analgesics. Paracetamol can be given with the dose of 50 mg per kg. If the diagnosis is uncertain and the patients look well, reviewing the child again is more appropriate than prescribing an antibiotic. If the child is observed without starting treatment, there should be a way to ensure the follow-up and begin antibiotic therapy if the condition of the child worsens or fails to improve within 48 to 72 hours of the onset of symptoms. The child of any age with severe acute otitis media or younger children less than 2 years with non-severe disease requires antibiotic therapy. Non-severe unilateral involvement in a younger child or non-severe disease in older children can either be treated with antibiotic therapy or offer observation with close follow-up. If acute otitis media is complicated or if the patient is immunocompromised, intravenous antibiotics are indicated. If the decision is taken to start antibiotics, amoxicillin is the first line of antibiotics that should be considered. Coamoxiclav should be prescribed if the child has received amoxicillin in the last 30 days or has concurrent purulent conjunctivitis, has a history of recurrent acute otitis media unresponsive to amoxicillin. In the presence of penicillin allergy, erythromycin, clarithromycin, or azithromycin can be considered. Choice of intravenous antibiotics includes coamoxiclav, cefuroxime, cefotaxime, or ceftriaxone. The duration of antibiotics. For children less than 6 years of age and children with severe disease, a 10-day course is recommended. For children more than 6 years of age with non-severe disease, 5 to 7 days of course is adequate. Azithromycin is given for 5 days. The day 1 dose should be 10 mg per kg and day 2 to 5 the dose can be 5 mg per kg once daily. If the patient fails to respond to the initial management within 48 to 72 hours, the clinician must reassess the patient and determine whether change in therapy is needed. The follow-up of patients. In infants with severe infection or children with persistent pain, follow-up should be arranged in 2 to 3 days. In any child who has been treated for acute otitis media, the follow-up should be between 10 to 14 days. An audiology referral should be made when any caregiver is concerned about child's hearing, speech, or language development, or when there are recurrent infections. Indications for an ENT referral: persistent middle ear effusion, complicated by mastocytitis, associated with facial nerve palsy, or recurrent acute otitis media. Thank you very much for watching this video. Subscribe my channel for more videos.